Welcome, everyone. Good afternoon or good morning, depending on where you are connecting from. Thank you very much for joining our webinar today. In the next hour and 15, you will listen to an in-depth panel conversation among expert speakers on the topic of surgery for deep brain stimulation in Parkinson's. We hope that following this session, you will feel you have more knowledge and more resources to discuss this topic with your doctor or nurse and other healthcare professionals, and feel equipped and empowered with the right questions to ask them. My name is Francesco Laurenzis. I am a Partnership Director of Parkinson's Europe. This webinar is organized by Parkinson's Europe as part of a multimedia campaign on deep brain stimulation and surgery. You can find more assets and read more about this campaign on the Parkinson's Europe website or by visiting our social media channels. Let me thank very warmly our excellent speakers of today, Dr. Alexandra Boogers, Professor Stephan Chabardès, and Ms. Janette Sinclair, as well as our moderator, Professor Alfonso Fasano, who are providing their time, their insights, and their expertise today. I also thank our industry sponsors, Abbott, Boston Scientific, and Medtronic, who have supported the making of this campaign from the very beginning. Before I hand the floor to the speakers, just a couple of quick service notes. There is an option to turn on translated captions with the button at the bottom of your screen, if you're not native English speakers. In the second part of the webinar, there will be a Q&A session when you will be welcome to submit your questions to the speakers using the questions and answers button at the bottom of the screen. So any questions you have will be addressed then. And finally, this webinar is being recorded, and the video recording will be made available via the Parkinson's Europe YouTube channels over the next few days. Now, without further ado, I will now leave the floor to our moderator, Professor Alfonso Fasano, who will introduce our speakers and then lead you through the conversation. Thank you very much.
Thank you, Francesco. Thank you, Laura and Parkinson's Europe for giving us the opportunity to discuss this very important topic. And also thank you all for attending this webinar. I actually came across a few familiar names in the list of attendees. So thank you all for being with us this afternoon or this morning, depending on where you are. We have a packed agenda, so let's start with the introduction. My name is Alfonso Fasano. I wear two hats. I'm chair in neuromodulation and professor of neurology at Toronto Western in Canada, but also professor of neurology and chairman of neurology at Humanitas University in Milan, Italy. As I mentioned already, we have important panelists with us today. I would like to start with introducing Ms. Janette Sinclair. She's been diagnosed with Parkinson's disease since 2013. She's board member of Parkinson's Europe and co-founder, board member of Action Parkinson's, which is a Brussels-based club organizing regular activities for people with Parkinson's disease. But she has an important story to tell us. I won't tell you what she considered to be her claim of fame. You will hear from her. But obviously, there's a reason why she's with us this afternoon. And also I have the pleasure to introduce two esteemed colleagues, starting with Dr. Alexandra Boogers, who is a consultant neurologist at Chirec Hospital in Brussels. I've known Alexandra for a while now because I also had the pleasure to work with her when she spent 2 years in Toronto with us, and actually happened to write several projects with her, and many more to come. And I happened to also meet her recently when I was visiting Brussels a few days ago. So it's nice to see you again, Alexandra. And last but not least, Professor Stephan Chabardès, who's been a colleague and a friend for many years. He's a professor of neurosurgery at Grenoble University. He's also the head of the Department of Neurosurgery at Grenoble University in France, obviously. He's the scientific director of Clinatech, which is a research center dedicated to microtechnology and neurosciences. And I would like to also say that when I was asking him what he would like me to say, he mentioned that is the most important thing, and this is really testifying what DBS can be, is that he's been trained by two giants in this field, Professor Benabid and Professor Pollack. DBS has evolved enormously in 30 years. I've learned DBS from other colleagues of mine that happen to see over time. I learned a lot about DBS from my learners, from my patients, but this is an evolving field, and really we had thankfully giants in the field, and we are all grateful to them and also to the many patients who underwent this procedure when it was considered experimental and now instead is standard of care. So this, I really like that Stephan highlighted that. And last but not least, is a sailor and a skier when he has time. I don't think he has a lot of time considering what he's wearing today. It's probably in between surgeries, but when he can, obviously, this is how he enjoys his life. Anyways, we're ready to start. Again, thank you all for being with us today. And let's give the mic to Janette now, who's going to tell us why she's here with us, why she was invited, and what's her claim of fame. Please, Janette.
Yes, my claim to fame, in fact, is that I had DBS in January this year, and so I've come here to tell you a little bit about my experience, and I hope it'll be of use to some of you as whether you're contemplating doing DBS yourselves. Sorry, excuse me. Start with the beginning. I was diagnosed, as you said, in 2013, so aged 50, and I managed the disease quite well at that point for quite a few years with exercise, and I was only taking agonists at that point, but then they became less and less effective, and I sort of hit a crisis in November 2022, and I stopped all of my drugs to do a sleep test. And I'd never experienced my condition without drugs, and it was really terrifying. And my neurologist at the time wanted to change my medication, but it didn't work very well. And I ended up taking increasing amounts of levodopa with limited effectiveness. And I started having full-blown panic attacks as well. And the situation wasn't helped by the fact that I was in between neurologists because my previous one had left the hospital. And in the last 2 years, life just became more and more difficult. I was finding it harder and harder to be confident to go out, and I was depending very much on my husband to go anywhere. And this experience led me to start looking for alternatives, that might be a better situation for me. And I started, the first big question for me was, could I get a better result with changes to my oral medication, or one involving a different medical device? There didn't seem to be much options, really. I think there is one drug called Ongensys that might have been a help, but it wasn't. It's not available in Belgium, as far as I'm aware. And I looked at the gastric pump, but it seemed quite invasive, nevertheless. And the other pumps that are now available weren't available at that. Well, they were just coming on stream, but they wasn't so easy to get some information about it. And I've been aware of DBS because when I had been first diagnosed, I had seen a British neurologist who had talked to me about DBS, and I'd even met the neurosurgeon. And I remember that he told me not to view it as a last resort. And he talked about having a window of opportunity for the operation when you're before the body declined too far, basically, I suppose. And it seemed to me that I could perhaps get a good result in that way, but nothing was guaranteed. If it was a good thing for people perhaps like me who were responded well to levodopa. It just when I took my levodopa, I did respond well, but it didn't last long enough. So, but apart from that, of course, you have no guarantee at all that it'll work with the DBS. And I then sort of went on to the next challenge, which was to look at who was going to do my DBS if I wanted to do it. And this is really important. I've got two surgeons here. Who would you let muck about in your brain, basically? And so you have to be very confident in that person, but also it's a process, the DBS. It's not just an operation, but it's also afterwards. It's a long-term relationship with somebody, with your neurosurgeon, the neurologist, to adjust it. So there were lots of issues there as well that came into play. And I was busy going around doing my shopping. Sorry. Ooh, are you still there? Sorry. Am I still there? I'm really sorry.
No worries. All good.
Yes, I was talking about finding the team. And I eventually went to Leuven, which is a city just outside Brussels. Leuven University Hospital is one of the biggest in Belgium, maybe even the biggest, and it has a very large neurology department, and it also has Parkinson specialists there. And at the time when I went to see them, they were just recruiting someone who was specializing in the DBS regulation as well. So I thought for all those reasons, it was a good place. You know, they had the competence there, they had the experts, and they had the team. The team under the neurologist, Wim van den Berg, Dr. van den Berg. And I met the surgeon, Dr. de Vloe, and I met him several times and he answered all my questions. He was very open, very flexible, and he explained all the risks, and we ended up with a good feeling about him. And basically, I think that's the best you can do, really, to have that feeling with someone who's going to be doing something so big to you. And then it came, up until then, I'd been really exploring, looking into options, but at that point, it was the decision time for me. And I had one real absolute criteria for myself, which was I didn't want to be awake in the operation. I knew that I had such an experience of panic attacks and things, so I just knew it was going to be, I wouldn't be able to face it. And so the key question to the surgeon was, could you do it with me asleep throughout? And he said he could, and cited some references that showed benefits of awake versus asleep procedures. And he was mentioning that he did similar operations asleep for other pathologies. And he also referred to the fact that the robotics he used helped with the accuracy of the placements, and which is, I think, the main reason why you keep the patient awake. And so once he'd said he could do it with me asleep, I just signed up straight away. I didn't have any other option, anything else in any other solutions in the way. And I just thought, well, I'm going to go for it now. And once I'd signed up, I asked for the earliest date possible. And it was June when I made my decision, and I had the operation at the beginning of January. So that was the first decision-making phase. Then came the second phase. Was I actually, sorry, excuse my language, I shouldn't have said that. Was I actually eligible? And there are two tests made, basically, that you have to go through. The first is what they call a levodopa challenge. And basically, you stop all your medication, you're filmed doing a certain number of simple tasks that aren't so simple when you're off your drugs. Then you start your medication again, and you're filmed again to see the difference. And for me, I did that in the hospital, and then it was sent down to the neurologist department, and they approved it like a school report or something. But yes, it came back, and I was okay. Apparently, I passed. So, and I think the thing about that is, I was led to understand that if you have if you have a good response to levodopa, then you're more likely to have a good result from the operation, from the procedure itself. And so I did have a very good reaction to levodopa. So that was quite good way of managing expectations, but also it was very positive for me to know that. And the second test was cognitive, to check you don't have any signs of dementia or any other problems. And actually, it was very intense. It's about 3 hours of all sorts of cognitive tests, but I actually quite enjoyed it. Well, probably shouldn't say that, but it was good fun for me. Although I was extremely tired by the end of it. So those were the two tests, and once we had the results, they confirmed that I could have the operation on the 6th of January, Epiphany. Yeah, so after that, I was just waiting to go in. Saw the surgeon another time to clarify a few points, and then it was much more practical side of going into the hospital and just having the operation. I did find it very hard to be. You have to stop your medication again before the operation can take place, and I did find that very hard. And the hospital was the people in the hospital were very good. They were very helpful, very friendly. And at the very last minute on the night before the operation, I just asked them on a whim if my husband could stay, because I was really quite worried about being alone and being off my medication. And they were fine. They looked a bit dubious at first, but then they went off and got in the sofa bed and the covers and everything. I thought that was really nice of them to do that. Then the next day I went off on my little trolley bed, really big hospital, loads of people in this holding bay for the surgery, but I did get off to the right place. And the surgeon was there, and everyone was there saying they were going to look after me, and it was very reassuring, except for at the very last minute after I'd spoken to the surgeon, and he just said good luck to me, and I didn't think I shouldn't have needed his luck. I just wanted his skills, but anyway, he was really, really good, and I was knocked out straight away, and I came back, woke up in my hospital room again. Quite a few hours afterwards, and I understand that that's quite common. People with Parkinson's do tend to apparently to react more and sleep longer after with anaesthetic. And what was I going to say? There was one other point that I wanted to make. Oh yes, it was very quick as well. It was only 4 hours, my operation, because he just managed to get on with it, and he didn't seem to have any. He was very. I'm going to leave this down, okay? So it's I've got it stuck here, but I'll leave it where it is if that's all right with you.
Yeah, maybe can you move it a little, because the audio might not be the best, because the mic is probably covered. Yeah.
Okay, I'll do it like this. I'll try and see. I'm sorry, I'm not in my home thing.
No worries. Just because this way we can hear you better. That's all.
Maybe that will be better. Okay.
Yeah,
right.
Perfect. Thank you.
And anyway, I'm going to come to the end. So I remember waking up and not wanting to wake up. I was having such a lovely sleep, but when I did wake up, I was quite surprised at how many stitches there were all over, and all the things all over my head. Nothing hurt. I didn't have any pain at all. I think just a slight headache for a couple of hours, but nothing else. But my head seemed to have much more than I was expecting. There's got 2 lumps there, but it's also got a very big wire that goes around here. And I guess it's obvious that it had to go somewhere, about the wires, but I hadn't really thought about it going there. So I did find that a bit strange. And the other thing was my hair wasn't shaved, but my head wasn't shaved. But the stuff that they used for the stitches, I think they put some sort of silicone or something, and it was just got in my hair. It was terrible. So I ended up chopping off quite a little bit of my hair and just to get the knots out and the silicone. And it would have been nice to have had a little bit of basic how to care for these, how to deal with it, because I think they had a special product that would get rid of it. Other issues are all very, very minor, but I do the wires here now are quite tight at the moment, so I would have liked a bit more information about physio for that. And finally, I would just like to say what my situation is now, because it's 4 months more or less since I had the operation, and I'm still in an active phase of initial, you might say, initial reglementation of an adjustment of the neurostimulator, and that is placed here, and I'm already extremely happy with the results, because I'm gradually getting my confidence back to go out, and that means I'm regaining my independence. And I started by just going to local shops for a quick walk and then staying out a bit longer. And then last week or so, I think I went alone to our association's World Parkinson's Day event, and that was a journey of about 30 minutes on public transport by myself and 10 minutes walk before each end. And I finished the day off by going to dinner with friends. And for many of you, that is nothing. And for others of you, those of you familiar with advanced Parkinson's, you'll know that that is everything, because it is just being able to go out and do something normal independently. And I think that was absolutely great. So I'm so happy so far, even if I do have some little niggles, but they're not important compared to the overall very positive result that I've had so far. Okay, thank you.
Thank you, Janette, for sharing your story with us, and thank you for trying to make it work with the camera. I'm trying to picture what's going on with your camera, and you are using a tripod or something. But regardless, it's been really a nice story, and I already have questions myself, but it's not my time to ask questions. We have experts who are going to tell us a bit more about what resonated hearing your story. I also want to take this chance, however, to tell the attendees that if they have questions, they can start typing them in the Q&A function that you see at the bottom. We did receive some questions up front. We're keeping these questions also into account, and we'll answer them later on. But now, without any further ado from my side, let's hear from Dr. Boogers, or Alexandra, what she can comment when it comes to your story.
Yeah, so thank you very much, Dr. Fasano, for your question. And thank you so much, Janette, for your testimony. This was very valuable, and I'm sure this resonates to a lot of other people, especially, I guess, the last few sentences where you said that for you, it means the world to be able to travel by yourself to a meeting with fellow people with Parkinson's disease. Because I think that when we talk about deep brain stimulation, when we educate people about what the surgery is about, we can always talk about symptoms and what's going to change. But I think most importantly, we have to set goals together, and goals that make sense in a day-to-day fashion, like not necessarily have less tremor, but go on the bus, as you said. So I think what is important in your story is really making these goals, defining these goals together before we get into the surgery.
Yeah, very good point. Actually, the community part, that the use of public transportation resonated with me too, Alexandra. You probably refer to the fact that it's being shown that in the mobility, the community the mobility in the community of people living with Parkinson's doesn't improve necessarily even after DBS, and this taps into something else that Janette was alluding to, the need for physio. We'll talk about this in a second, but let's hear from Stephan what instead resonated with him.
Yes, so thanks for sharing your experience, and it's a very recent experience that you had with surgery. But I also took attention of what you said before surgery, before you had surgery. Of course, is very important, because I don't see this part usually. I see when the patient are ready to go to surgery, and then they are almost confident. But some words are very important that you mentioned. For example, you mentioned very early that you need to have some guarantee of surgery, of results, or at least to have some idea of what's going on, which is very natural, because when you go and have a brain surgery, you must have at least some you have to envision what will be your result, even if you say in surgery that we cannot say that we will have 100% guarantee of results, but we have some data, we have some experience, and we can say that, for example, you mentioned the response to DOPA. It's a very big argument to say, yes, you can go to surgery, and we should have something that will be very close to what you got when you are at the best DOPA level. Also, we have to think about complication, and we know now, because we have a lot of experience for 30 years, that the complication rate is quite low. Of course, depends on sometimes you say luck. I don't say it's always a luck. It can be, of course, some luck, but also the teams, your own health before to go to surgery. I heard about the word of being confident with the team that you are engaged with. Of course, it's very important with the neurologists, because they will tell you, yes, now it's your time to go to surgery, but also with the surgeon. And you mentioned that when you met your surgeon, you were in a good mood with him. That means that you were ready to give at least some. I won't say your brain, but of course, yes, a little bit. You will have to give to be very confident. Of course, I know that it's very, very, very important and very difficult also to, and so it is. It's also it links with another word that you mentioned. It's the window for surgery. You have to be ready to go to surgery. You must not push by your family. You must not be pushed by your husband or your wife, or even by the neurologist. You have to be ready to go for surgery. Not too late, not too early, at a good moment. And this is very important, because then you have to be, of course, you have to get some advice from the neurologist. They know deep brain stimulation. They know what will be the best opportunity for you to go to surgery. You mentioned also, it's more technical, but asleep versus awake. This is very important, because when we start to make surgery 20 years ago, we were always operating people awake, and the surgery was lasting 24 hours, at least in France or in Grenoble, we had very good results, and that was the pioneer that allowed us to have this kind of a good result. But then we figure out that we have also some side effects nowadays, and people have started to operate under general anesthesia many years ago. But most of the team now are operating. I won't say most of, but a lot of teams are operating patient under general anesthesia, and the results are the same, because we have acquired experience. The results are the same in terms of benefit of the surgery, but the how do you say, the complication rate is a little bit low, and I would say for the patient, the burden of surgery is much less. So people are more prone to go to surgery because they need it. They are not scary about surgery nowadays, and I think it's a very big step that we did in the last few years. So that's my first comments on what Janette shared with us.
Thank you, Stephan. Actually, you touched the point, a question I was going to ask yourself about asleep surgery. So I'm glad that you went there, which taps into one aspect that affects many people who live with Parkinson, and Janette herself described that, which is the anxiety in the off state, or sometimes people have pain in the off state or dystonia. So I think the take-home message for our attendees is that DBS is no longer requiring necessarily that the patient is awake, because some people are scared about it. Think about the fact that we do these procedures in children or in people with very severe symptoms or signs, so not requiring, requiring obviously an asleep procedure. So things have changed for a number of technical reasons. We won't go there. I have some question for Alexandra, also some question for Janette. But before I go to them, I have a quick question for you, Stephan, because one thing that Janette reported, which is something we hear a lot from patients, is the cable. So she feels the tension, and in case people don't know, everything is inside the body. Janette has very, you cannot really tell that Janette had surgery because first of all, she has hair, the hair covered the burr hole. If I were to have surgery, as I tell my patients, you will see maybe something up here. Janette most likely will have a scar here on the right side or on the left, depending on the procedure, how the procedure is done. The cable usually is not visible, but if people are very skinny and they turn the head, you may see a little string under the skin. And in some people, this can be annoying. They may feel the tension, as you heard from Janette. So, Stephan, I'm sure this happens, I don't know how often in your case, in cases too. So what's your take about this?
So it used to be very important when the stimulator were very heavy. We had a big stimulator and they were attracting the cable. So because we had this issue many times or sometimes, nowadays, first of all, the batteries that we have are much smaller. So the weight of the battery is much smaller. Then we have some cable that can be extensible. So it helps a little bit. And then because as we have a quite this experience from the patient, because some of them, I saw them, some of them with the cable. Now we try to be sure, we pay attention to be sure that the cable is not pulling, the battery is not pulling on the cable. So this is what we observed in the past, and we still have sometimes this kind of experience, but it's less and less. And of course, for us, it's a detail, but the details are very important because if you cannot support, you cannot, stand your battery because of this kind of detail is very important. And sometimes we have to reoperate just to push a little bit up the battery, but it's very rare. So we pay attention to that, and thanks to the technology that has evolved, now the battery is much smaller. Even the rechargeable are even smaller, and that you can put it under the skin or under the muscle. In case of patient are very skinny, which is sometimes happens.
Yeah, so Stephan introduced a term that some of you might not be familiar with, that is rechargeable. So some devices are meant to be recharged and they last many years. They can last 15 years or even longer, even in some cases reported up to 25 years. So this means that the battery is smaller because the battery doesn't have to keep the charge for so long. I would say most people with Parkinson's, for what I can tell nowadays, are getting not the normal battery that is not rechargeable. And this battery may last between 3 to 5 years, depending on how much energy is being used. So this is just to clarify what you heard from Stephan. Just a clarification, Stephan. So because it happens to me too. Some people complain about the cable being too tight. And sometimes my answer is, well, let's wait because maybe over time things will get better. And as a matter of fact, things get better. I don't know, Janette, do you feel that the tension is getting less or so? Or...
No, but I think it feels a little bit like the stimulator is moving up a bit, and I was advised to wait and then see the surgeon. So when I go back to Brussels in 3 weeks, I will then make an appointment to go and see the surgeon, I think, because it is still, and it's making me put my shoulder in a bit in the wrong position as well. So.
Yeah, but waiting makes sense because, like I said, I think that sometimes things get better. So, Stephan, is this in keeping with your experience, or if it starts, it's not going to go away?
No. You have to wait because you were operated very recently, so the fibrosis that can get around it's very fresh. So you have to wait a little bit, and then you will get used. Then sometimes we see some cases where the battery is pulling on the cable, and this is something that will not be not disappear. But usually this kind of strange feeling on the cable usually disappear within 4, 5, 6 months.
Very good, thank you. So now let's move to again building up on what we heard from Janette. Let's move to Alexandra because I would like Alexandra to guide us through this window of opportunity that we were discussing about. Because as you also actually Stephan himself emphasized that even though in theory the neurosurgeon receives the patient from the neurologist, so it's important that this window of opportunity is known to patients, is known to neurologists, and I'm glad that it was picked up by the neurosurgeon as well. So the question, Alexandra, is window of opportunity, but in a more practical sense, why not do it too early or why not doing it too late? Because it's not just that sometimes it might be too late, but sometimes it might be also too early. And this taps into one of the questions that we received in preparation for this event today. One person was basically saying had the disease for 6 months, my neurologist wants me to be on drugs. I don't like drugs. Why can't have DBS right away? So can you guys can you guide us either way, the direction, the early versus the late reason to avoid the window?
Yeah, absolutely, for sure. I think first of all, it's important to say that this window is not just like 1 month or 6 months. So it's not like we really have to sit tight until that window appears, and if we're too late, it's gone, right? So first of all, to the patients, we shouldn't be afraid that this is a very narrow window. But indeed, too early and too late is a bit of an issue. Too early, as in 6 months after diagnosis, is indeed too early, because people with symptoms that go with Parkinson's disease, extremely rarely, this is not a typical Parkinson's disease. So time needs to tell you a little bit about whether or not it's a typical Parkinson's disease. And roughly speaking, you need about, let's say, 3 years of symptoms before you can differentiate, sometimes even a little bit more, but 3 years more or less to be able to differentiate whether it's a typical Parkinson's disease or an atypical Parkinson's disease. Also, in typical Parkinson's disease, the disease will respond to levodopa. So we really have to make sure we give it a good try. And usually, let's say that the window kind of opens when we have symptoms that respond very well to levodopa. But let's say 2 hours, 2.5 hours after having taken the drug wears off, and the patient has more of these symptoms of slowness, of stiffness, of gait difficulties. And then after the next dose, again, the dose helped, but then wears off after a few hours. So that would be a typical person with what we call a fluctuating disease. So we really want to be somewhere there in that region before we talk about DBS. And not to mention that this can co-occur with dyskinesias, like the involuntary movements that can be extremely troublesome for our patients. Now, too late would mean that, for instance, our patient has severe cognitive difficulties, or when the patient is on the drug and when the drug is working in what we call the best medication on condition, meaning that the drug is working, that even in those situations, the person is unable to take care of themselves, like they're bed bound in these situations, then we usually say, okay, now we're a little bit too late, right? So too early, it's not good, too late, it's not good, but usually when you have this fluctuating motor disease with or without, most often with dyskinesias, that we usually call the window.
Yeah, absolutely. Thank you for clarifying. So just for the audience, you need to have responsiveness to levodopa, but levodopa doesn't last long enough or has dyskinesias. Just to complement what my colleague just said, an exception to this rule is tremor. So
Correct.
Sometimes tremor doesn't respond well to medications. And in this case, however, DBS will still work. Now let's move to Janette. Very quickly, Janette, because you already alluded to it, but I think it's important to go in there again, and maybe we can hear the experience of Alexandra, because she's done this with patients. So you mentioned, I think a couple of times, that when you were going through the testing that we do before doing the procedure, you were quite anxious about passing the test. You passed, and therefore you got DBS. And obviously this, in general, any test makes us anxious. And this might be even more of a problem if you're already an anxious person on your own or because of Parkinson's. So is this how you felt? Were you afraid of not passing the test and therefore not being given the option of DBS?
Not really, no. I wasn't. I was more anxious about actually doing the test, because they were quite. It wasn't very nice to be with no medication. That was the main issue. I did think that it was presented to me a little bit in a jokey way that you passed, you've passed. But yeah, no, I thought it was. I had understood that they need to be as rigorous as they can be, because it's more likely to get a good result if they're really rigorous about the checks that go through there. Does that make sense?
Yeah, no, it does. No, thank you. I'm happy to hear that, because in reality, when we do the test, it's never a yes, no answer. We do this testing to understand what's the risk, what to tell the patient and the family, what to expect. So I don't want people to feel that they are going to, to take an exam and they might fail. It's not, you guys have enough problems. We are here to help. But
Yes,
in order
I'm
to help,
sorry if I gave that impression as well. So.
no, not at all. I actually, just took the advantage to ask you this question, and also to give Alexandra the opportunity to discuss an important way we have to lessen the anxiety around the procedure, which is education. So, Alexandra, this is your baby.
Yeah, my baby. Yeah, correct. Yeah, so we had this huge privilege about 5 years ago to start an educational project, which started off in Leuven in Belgium, to actually, as a group, educate patients about DBS patients and their caregivers, because I really believe that it's very important to involve caregivers in the process of education. And so during this guided tour, we show videos of patients who underwent, like Janette, DBS, who share their experience, as well as we show information about outcome, but also specifically about side effects, right? Because we haven't tapped into side effects that much yet. Now, it's not only available in Leuven right now, but also in Toronto and 3 other centers across Europe, because we really are advocates for education, because we've seen that the better a patient is educated, the patient and the caregiver are educated, the better the outcome is, the better the satisfaction is. Because if you know what to expect, you have your expectations right and realistic, that really takes you back to a happy patient.
Absolutely, and thank you, Alexandra, for walking us through the issue of education, and that's the reason we're doing things like today. And again, thanks to Parkinson's Europe for giving us the opportunity to educate the public. As a matter of fact, we already receiving some questions, and we already answered one of them about the windows of opportunity. But I want to have a second before we get to the formal Q&A part. To go back to what Stephan said when he basically was saying, every center has their own statistics. So every center may tell you this person, in our center, we have a rate of, infection of such, or other complication of another percentage, which is another thing to emphasize when we educate people. So when you go to see your neurologist and your neurosurgeon, don't be afraid to ask these questions. And the question is not what is in general that is happening in the world, but is in your experience, how often you've seen this, how you do it, what's your fear. So actually with another patient of mine, Benjamin Stetcher, we wrote about this, and we wrote a sort of a checklist. What are the questions to ask? So don't be afraid to ask questions. Stephan, is this how you discuss things with your patients?
So usually when they are coming to visit me, they know a lot of deep brain stimulation because they were educated by the neurologist. Of course, we have a special group where the patient, they can meet all the patients that have been operated before, which is very, very important. But usually when they go back and when they come and see me, they have the same question, but they need to repeat the question because I'm the surgeon. They need to, not to check, but to see, to be confident on what they could get. So usually they have the same question. Sometimes it's a very, very stupid question, in my opinion, but which is not, because I'm so used to do that. But for the people, it's always the first time. So how long the surgery will last, how many suture I will have, how many point of suture I will have, this kind of things. But this is, for me, it's not very important. But I know that for people it's very important. The length of the scare, will it be visible? Because it's a matter of it's very important. But usually people, what they ask is the most common question they have is the complication rate. What can I'm a little bit scary. So do you think it will go well, etc. And what can I expect? Can I expect to go back to work, to have to play tennis, to go and ski, etc., etc. So very things that they used to do in the past, they're not doing anymore. They want to go back, and sometimes we have to tell them, yes, this is possible. Usually I say you will have to go back to a normal life, but you will have been operated, so you have to be full sometimes. So we try I try to minimize the risk and the limitation that they can have with surgery. But of course, they have to be aware that we perform surgery on them, and they have to wait a little bit before to be able to do what they want. But usually we try to make them confident on the fact that they can do what they want as soon as their health allow them to do it.
Thank you, Stephan. Actually, your answer is transitioning us perfectly in the Q&A part, in particular a question asked by Anne-Caroline. And don't worry, guys, we're going to go through all the questions that you're going to ask. Obviously, question about DBS, and ask me about politics because it's not the right moment. But let's go back to Anne-Caroline because she's asking two questions. That one of them is particularly relevant to the idea of playing sports or stuff like that. Because Anne-Caroline is asking Janette, first of all, she's thanking you, Janette, but she's also asking if you experienced some limitation or some new problems that you didn't have before DBS. And then she's also asking what feedback you got from friends and family. But let's talk about, first of all, how life has changed. What if you have experienced new problems that you didn't have before, or new limitations?
The one problem I'm still doing the initial regulation adjustments, so it's a bit too soon really, but I'm having a bit of a problem with my bit of possibly dyskinesia in my left arm and also my left foot. So I think that maybe we need to adjust for that side, but I'm not going to do it. I'm actually on holiday at the moment, so my device is locked and I can't touch it because the team is in charge of agreeing the adjustments that I'll make at this stage and then giving me parameters for it. So no, I haven't. Apart from that, I haven't had anything new. The one thing I didn't mention, but I should mention, however, is that I put on quite a bit of weight. So and health-wise, that's not really the best. I had read something that said that people, on average, people with Parkinson's might have put on the equivalent of about a stone. I think it was about 8 kilos or something, in a year. But for me, it was almost within a couple of months. So I should have been more attentive to that. But otherwise, no, I would say that I haven't had anything new.
Okay. Well, the one thing that you've been emphasizing, actually, I had a question about this later for Alexandra, is the fact that you're still in the programming phase. Right? Some people think that you got surgery and you're done. Programming takes time. You had surgery in January, and you're still saying, well, some fine tuning is still needed, and these conditions can be a side effects of stimulation. So before we go ahead to the second part of the question that Anne-Caroline asked, Alexandra, because you program these patients with DBS. I don't think Stephan does it because usually it's a neurologist's job. But in case Stephan, you want to chime in, please feel free. But Alexandra, do you have any comment, for example, when it comes to occurrence of freezing of gait? This is a question about freezing of gait or problems with swimming. So why don't you tell us what happens in some cases?
Yeah, absolutely. I think these are two good points. So first of all, freezing of gait is a very difficult problem, right? It's because freezing of gait can improve when you take your pills, can worsen when you take your pills, or can be worse when you do not take your pills. And equally with DBS, the freezing of gait can improve, but very rarely it can worsen as well. So it's very important to discuss very well in advance with your neurologist and define whether your freezing of gait is responsive to levodopa, because if it is, it may respond to DBS as well. But if it's not, then very likely it won't respond to DBS either. So for freezing, it's very important to not make that goal number one, because then you may be disappointed. Our goal number one is usually to give you more of this on time, not improving the quality of the on, but giving you more of the on. The second point that you said, a part of the freezing, hold on.
The swimming. Swimming
yes.
Or coordination in general.
Excellent point. Because indeed, people after having been programmed with DBS may have a little bit of trouble with their spontaneous movement, which you need to be able to swim. And that is why after DBS, we usually encourage people to swim on the shallow end of the pool, make sure someone is there, to just make sure that everything is safe, right? Usually you can learn to swim again if that is necessary, but people have had issues. So therefore, it's very, very important to make sure that the first time after surgery, there's someone's there and the water is certainly shallow.
Thank you, Alexandra. Sorry, I'm keeping an eye on the questions. We just briefly, because we got a question about how if family or friends have seen Janette's change. Because we have questions to go over. Janette, I would like just to ask you a very straight question. Do you think your friends and your families have seen and reported to you things that you haven't seen? Or they're more or less aligned with your sense of improvement?
They probably think that I've improved even more than I do. I think. I mean, my husband said he just felt that he got me back. That I'd gone. The person I was had gone, and that because of Parkinson's, and then now back. So he's quite happy with that, and he's pleased. Yes, and I think for my mother also. I think it was quite hard to see me declining. So it's really nice now that she's seen me better as well.
Okay, very, very good. Thank you. So now let's switch gear and let's talk a bit more about the post-operative phase, because there is an anonymous attendee who is actually going to have surgery, in less than a month or so. It's on May 27th. So I hope this person is not too scared and is more confident after having heard this webinar. But the question is very specific. By the way, is tuning in from South Africa. But the question is, how long is the recovery after surgery? Stephan has already alluded to it a little bit, but Stephan, do you want to add something to this question?
Yes, so it depends on if you are operating under general anesthesia or local anesthesia, because paradoxically, if you are operating the general anesthesia, usually you recover very fast, because after 1 hour after surgery, you are totally awake. And then in our case, people, they don't go to the intensive care unit, they go directly to the normal room. Depends on the hospital, of course, and on the teams. But usually my feeling is that people who have been operating the general anesthesia, they don't have to go through off DOPA, because when we are operating under local anesthesia, people are off DOPA, and that makes people a little bit, how do you say, tired, etc. So usually, I would say that after it's a surgery that you don't need to open the cranium. You don't open the brain. So usually after 24 hours, you feel very good, and people are working on the corridor or on the room. And usually in our centers, on the day after surgery, they go to the neurology department to be ready to start the stimulation phase, which will last some days. But recovery of surgery is quite fast. Within 24 hours, you are good.
Very, very good. So this is unfortunately reassuring. But sometimes people want to ask, though, when can I go back to work? Because some people with receiving DBS are actually working, and I'm sure you don't say you can go back to work the next day. So what's the the convalescence, more or less? So how many days they need to take off?
It depends on the country.
But can you say they get
between one and 2 months? Depends on the patient, depend on the willingness to go, depend on the work they are doing. If they are hard work, doing very hard work, it will take more time. If you are in the office or in front of your computer, I would say that takes at least 1 month, and then after 2 months you should go back home. We should go back to work.
Yeah, this is what we say. We usually say 1 month, but you're absolutely right. It depends on the job. So now surgery is done. We talked about the recovery phase. The patient is discharged. By the way, the fact that you get surgery sometimes makes some improvement. But now I want to touch to this sequence of events. The question that Sergio asked us in Italian, but I use Google Translate, and I translated from Italian because I don't speak Italian. So I know. Of course, I'm joking. It's my mother tongue. And the question is, how soon you will see the effect? And I would say, obviously, inserting the electrode improves things a little bit. It's called lesional effect or stunning effect, and then symptoms of Parkinson's come back. And then the patient is seen by the neurologist for the programming. So let's ask first Janette and then Alexandra. So Janette, if I ask you, when did you start seeing the real benefit of DBS? How many weeks or months after surgery can you say?
When did I see the benefits?
Yeah.
I had a month between the surgery and the switching on. So the switching on was 10th of February, but then it was more or less straight away. I mean, it wasn't a high enough dose yet, but it was quite quickly starting to be the right dose.
Perfect. Alexandra, do you want to add anything to this?
Yeah, sure, because Stephan alluded also a little bit to their way of practice in Grenoble, where the system is switched on the following day. I was trained in Toronto differently, a little bit like Janette's experience, more like we wait about a month, sometimes 6 weeks between the implantation and the first programming session, meaning that first month after the surgery, you take your pills the same as you did before the surgery, and only then we start to set up the stimulation, we start to slowly decrease the programming. So my personal approach is slightly a bit slower, meaning that we see the patients every week for 4 consecutive weeks, very slowly taper the medication, increase the stimulation. And when you do this regimen, then usually the effects are seen the second, sometimes even the third programming session. So if you count these 2-3 weeks plus that 1 month in between surgery and the start of the programming, then you're more seeing the effect, let's say 2 months after the initial surgery. So it depends where you put your time frame.
Thank you. Okay, so now we're going to put Alexandra on the spot. Oh, sorry, Janette, please.
Can I just say one thing I forgot to say?
Please.
Well, as the device is switched on and ramped up, the drugs are reduced. And at the moment, I've reduced my levodopa by about 80%. I'm just taking 1 tablet a day now, and I've also I'm only taking 8 milligrams of Requip. So when I was taking 14, so it's really made a difference that way. I'm hardly taking any drugs at all compared to before.
Yes, Janette, and what you just raised is the reason why we do things slowly, because we need to lower medication, and if we reduce the medication too fast, people might have depression. But let's switch gear, and as I said, I'm going to put Alexandra on the spot, because Alexandra, now you have a very difficult task, which is basically trying to be effective with time management. We had a number of questions, and I would like to condense them into one. Basically, people are asking, sensing, adaptive, what is it? What's the difference? Can I have adaptive? Can I have sensing? AI? Can you just give us a summary, maybe tailored to Europe, because otherwise it gets too complicated, just in a minute or so that we can move on with other questions?
Sure. Yes, absolutely. So I think these are all important things, important words, but all in all, both AI, sensing, and adaptive, it sort of means the same. Basically, we have 3 players on the market. Abbott, Boston, and Medtronic. And Medtronic has this device on the market which allows sensing, meaning that the electrode does not only send stimulation to the brain, but can also listen to the brain. It can listen to how active these cells around the electrode are. The more active the cells, the more stimulation you need, and vice versa. And that is what we call adaptive, because the stimulation amplitude, the amount of stimulation that is given, adapts to what the brain actually says. So it senses. And if you will, it uses AI to sense the brain. Hence, actually, it all means the same. So this is a treatment that has been launched in Europe a couple months ago. It's very new, off the press. We've been doing the studies globally, and we see that the first outcomes have been interesting. So this is one of the devices that is available, as well as the other companies are, but that is something that should be talked or discussed with the surgeon and the neurologist at the particular center for sure.
Perfect. We killed few questions in even less than a minute. Thank you, Alexandra. And I appreciate that you listed the players in the market in alphabetical order. So very, very nice. Thank you. Okay, so let's switch back to Stephan with some technical questions, because James is asking about the MRI compatibility and also the compatibility with the pacemaker. This person is a cardiac pacemaker, which can happen, and it will happen more and more in the future as we have more technology embedded in our body. So what are the precautions, Stephan, when it comes to MRI, pacemaker? And this also connects with a question that we received up front from one of our attendees, I hope today, who got DBS in January 2024 with good results, but is being warned about magnetic sources and is a bit concerned, or she's a bit concerned because of, hobbies and security at the airport. So can you guys, can you tell us about MRI, security, magnetic field, compatibility in case you have another device in the body? So even I put your also your case you on the spot to see whether you can condense in a quick answer all these questions.
Yeah, of course. So MRI compatibility is very important, and in the past we did not have this kind of possibility. That means that people who had the brain stimulation, they couldn't have any other MRI, which was a little bit problematic. Nowadays, all the equipment that we have, they are MRI compatible. That doesn't mean that they can go anywhere to have an MRI. They can have MRI in some circumstances where usually the radiologist is aware of the patient who has the IPG. So MRI compatibility, it's a very good progress. You can have an MRI if you need for back pain or to follow a cancer, something like this. But that must be done in a team who is used to make MRI with this kind of machine, with this kind of IPG implanted in the brain. So it's nowadays possible with some how do you say, cautious. When you go to the airport, well, what can happen is that your people, they will see that you have an IPG, because usually take an X-ray. There is no risk at all. I never heard about any risk. So and then usually you've got a card, like people who have a pacemaker. There are many, thousands of people having a pacemaker that they cross the border and they cross they go to take the airplane. So I don't think it's an issue. Usually there is no interference between the machine and the IPG, so there is no risk. You have to be careful with sometime. You have to be careful with, in the past, when they have some how do you say, aimant, there was a kind of a circumstance where you could have a switch. You could switch off your battery because it was very sensitive to any electromagnetic field. I think nowadays this is not the case. It's very rare, so usually it's safe, I would say. So first of all, MRI compatibility, yes, but you have to be cautious and in some circumstances, and then X-ray or going through the airport, etc., no risk.
Perfect, thank you. Good job also with time management, as Alexandra did. So switch back to Alexandra now. Quick question, which I ask you, Alexandra, as a Belgian, but also as a neurologist who knows about this, the companies and devices, without getting into much detail. One of the questions was about the coverage of DBS in Belgium, but I think in general this will apply to most European countries and more or less the cost. But cost obviously changes country by country depending on the contracts. I will switch the question more I will change the question more in terms of direct cost to the patient, not cost to the device or surgery. So, and obviously you need to give an answer more in general, let's say European countries. So is it covered? What is it not covered? So that is the question the patient going to be covering.
I think in Belgium for sure, and I think in most European countries, DBS for a typical Parkinson's disease is completely covered. So you will get what we call a small bill that the patient needs to co-pay. But in Belgium, 95% of the surgery and everything that is entailed with it is being covered.
Same in France.
Yeah, I would say, same in Italy. And so this is the good thing about Europe, and the good reason to pay taxes. Okay. Okay. So now let's move on. Again, another question for you, Alexandra. For very quickly, someone is asking, can I drive after DBS? And the other question is, can I start writing again after DBS?
Start writing, like writing. Oh, that's actually a very nice question, the rating, because your fine motor skills are often very much impaired by Parkinson's disease. And if these fine motor skills are impaired because of tremor, and tremor is very well addressed by DBS, I can imagine that you are able to write again very well. Now, most often, so DBS can treat very well slowness of movement and stiffness of movement, but because writing is a very difficult fine motor skill, I can imagine it improves, but will it go all the way as it was like at the diagnosis? That I think we have to be a little bit patient with in terms of our expectations. In terms of driving, I think every country has their own law. Belgian law is for sure different than French law, for instance. Usually I say, let's wait after the surgery, purely the surgery, at least 6 weeks after the implant, but also feel confident in terms of your movement. And the comparison that I always make is maybe you can drive, but the problem is you have to be able to speak your mind whenever you're in an accident, right? Imagine you're in an accident, you have to get out of the car, speak for yourself, talk to the other person involved, and that is how confident you need to feel, in my opinion, before you start driving.
Well, discussing a bit more the confidence, I will add to this, Alexandra, which is important to emphasize today also, given what you said before when you talked about caregivers. The family needs to be involved in this decision. Obviously, you don't want to drive right after surgery, but I will add, you don't want to drive right after programming, because programming can cause impulsivity. It doesn't happen often, but people might become too confident, too impulsive, too happy, manic sometimes. So you might feel you're a great driver, but you're actually not a good driver. And so it's also important to keep an eye on this and get the family on board before making such decision. I always say this, probably I told you when you were in Toronto, a patient of mine, he did extremely well with DBS. He stopped all medications. We're going to talk about medication soon, by the way. And he wanted his life back. He went into a ride with his bike, going so fast, got into an accident, fractured the femur. So this person wanted to get back to his life too soon and get himself into troubles because of that. So there's people will drive, but it's important also to don't rush into anything like that can be dangerous. I mentioned the medications, and also when I hear from Janette, because we haven't heard from her in a while, I'm also wondering if the phone is still holding up, and we'll see whether it falls down. But talking about medications, I mentioned earlier that tremor often is resistant to medication, because this is one of the questions that was asked up front before today's webinar. So sometimes tremor doesn't respond to medication or requires high doses of levodopa. And the other question about drugs is whether there is a connection between Parkinson's and drugs that cure tinnitus. In reality, there is no a real connection. However, some drugs used for vertigo can worsen Parkinson's or can trigger Parkinson's. So I don't know the particular drug that this person is referring to, but the bottom line is that you always need to ask your neurologist whether any drug, not just the neurological drugs, because some drugs can actually have an effect on Parkinson's. Now, let's go to Janette, and then we hear from our colleagues. Janette, you're taking very little levodopa now. You're taking a decent amount of a dopamine agonist, ropinirole, and I understand why this has been done, because dopamine agonists are more difficult to wean off because of depression that can be triggered by reducing the medication. Do you think you'll stop levodopa one day?
I'm taking so little that it's quite possible.
Yeah. And that's exactly what I wanted you to go, because one of the questions is whether levodopa can be stopped. The answer is they can happen, especially if you do very well, like Janette, but not always. So the goal is not to reduce or to stop medications, but to make you feel better. Alexandra, Stephan, any comment in this regard?
Yeah, for us, it's quality control. When you can reduce the amount of medication by 50%, 60%, which is usually a good level. If you cannot, it's because sometimes the DBS is not so effective. But usually we can, but we don't want to stop all medication, because then some, as we know, some symptoms who are responsive to the dopa, but who are not responsive to the brain stimulation can worsen. So usually, in average, people when they can reduce by 50-60%, but no more. Yeah. To make it short.
Yeah, I like that. So reduction of medication should not be a goal. It should be a secondary effect. The goal should be to control the symptoms well, and secondary, we can reduce the medications. And indeed, as Stephan said, 50-60% is roughly speaking the average.
Okay, well, Alexandra, since you're talking, I want to again ask you two quick question that tap into the selection of patients. One person is asking why cognitive impairment. This is Deepak. Why cognitive impairment is not is an exclusion criteria for DBS? Question number one. And then also Susanne is asking. Susanne has asked other questions, by the way, before. Is asking whether the younger you are, the better it is. We are well within the window of opportunity. So this is about selection of patients.
Yeah, very good questions, both requiring a bit of a nuanced answer. So cognitive impairment is indeed a reason for exclusion. And now we're talking really not just about very subjective, I forgot where I put my keys, because that honestly happens to me too, but about dementia, real full-blown dementia. And real full-blown dementia, that is an exclusion criterion for Parkinson's disease. Because what happens if we do DBS, sometimes there's a little bit of a worsening of Parkinson's disease, about the cognitive abilities. So you don't really want to push it further for sure. Also, when we treat patients with the brain stimulation, it's very important that they bring us back information, because this information is very important to be able to do the programming. And if the person is not able to report back on how their life is, it makes this very difficult for us to help in terms of programming. Secondly, in terms of, is it better to do it younger? Generally speaking, yes, but as mentioned, that window of opportunity needs to be respected. And actually, I want to say basically the opposite. If you're older, it's less interesting, right? If you push your age is pushing towards 70, then you might be starting thinking, okay, maybe DBS is not the perfect solution. However, we've treated patients with Parkinson's disease who are 75, who have a lot of tremor, who basically almost run a marathon, and these people may be eligible, while someone else who is 65, who has different other diseases, may not be the perfect candidate. So that's why it's a very fluid idea about this 70-year-old cutoff that's usually used for PD.
Amazing. Thank you. Well, it's so rewarding to see that we covered all the questions. We answered them all. So please don't ask questions. Otherwise, my OCD will be triggered. So we're about to conclude.
You can treat it by deep brain stimulation.
Yes, of course. So we're about to conclude this webinar. And in doing so, I want to really thank from the bottom of my heart, Alexandra, Stephan, for the contribution. And more importantly, sorry, guys, Janette, because Janette, has described and shared her experience. It's not easy all the time. I realize that. So we are extremely grateful to people living with the disease, because we are part of the same team. And through the conversation, the one we had today, we really make this field better day by day. And now my turn to give the mic back to Parkinson's Europe, thanking them for the opportunity to host this webinar. I hope we'll have the chance to have other events in the future. For sure, there will be other events in the future, even without me. Go on the website, because they do a lot for patients and patients awareness. So, you will learn a lot just simply going there and following what their activities and what they do. So back to you guys. Thank you once again.
Well, thank you very much, Alfonso. Thank you for conducting and moderating the session so effectively so far. I mean, we've answered a lot of questions. I think we have last one from Sergio from Italy, if I may, asking if you need to be careful about anything with the battery pack under your chest, if I read it correctly. I think we have just 1 minute to answer this, if possible.
Yeah, who wants to take this very quickly? Alexandra, Stephan, I can answer. Yep.
The most important thing is don't put direct heat on the battery pack, right? So no direct heat, because that may be not as interesting for the battery, but I'm not sure if.
Yeah, like sauna, for example, because the battery is metal and there's metal connected. You see what happens. Metal can transmit the heat itself, so you can cook your own brain. So don't want to scare you, but don't put anything hot on the battery. Don't go to a sauna. And then you heard already about the compatibility in terms of MRI, security. But in general, you can have your life. This is supposed to help your independence. You heard it from Janette. She said she's more independent now. This is not going to make you a slave of technology. The goal is to make you independent, but you need to know the rules. There are a few things that you need to be careful with, but not too many in the end. So I hope we answered Sergio's question. Back to you guys.
Thank you very much. Yes, a very important last practical question. Well, again, we are about to close this webinar. As I was saying, thank you very much, Alfonso, for conducting the session so brilliantly. And thank you, Alexandra and Stephan and Janette, for providing a huge amount of insights and expertise, and Janette for sharing your own individual story, which I think will resonate with a lot of the people who were with us today and who will hopefully see this video afterwards. So thank you all for making time to be with us today, and thank you to our audience who followed us until now. As Alfonso was saying, please, if you want to know more about the campaign of the work or the work of Parkinson's Europe, go visit our website, parkinsonseurope.org. And yes, you will find other assets and resources that we developed about DBS and surgery as part of this campaign. And last but not least, again, thank you to the industry sponsors who supported this campaign from the beginning, Abbott, Boston Scientific, and Medtronic. It was great having you all today. So thank you again, and yes, we can now close the session. The video recording of the session will be made available on our YouTube channel very soon over the next few days. Thank you again.
Thank you, everybody.
Have a good afternoon, morning, evening, everyone, depending on where you are in the world. Thank you.
Bye-bye.
Thank you.
Bye-bye.
Bye.